any questions from the floor to any of the three speakers so far this morning? Yes, sir. And I will just ask one thing.
Sorry.
Can you introduce yourself and say where you're from, if possible, as well, please?
My name's John. I'm a nurse who working for a trust, NHS trust in Sussex University Hospitals. I work in neuro rehabilitation. I'm quite passionate about patient engagement, but I still find there's quite a lot of resistance. For example, I'm not naming anybody because my colleagues generally are great, but my colleague in practice education is reintroducing a course for neuro-trained nurses in particular, and he asked me my thoughts, what are the essentials, and I talked about that, but I also said, I think a great start would be talk to the patients, talk to the visitors, their relatives. So he said, oh, John, I had that idea as well, but when I put it to the two key stakeholders, I won't give their titles, they were absolutely resolute, absolutely no way you're approaching patients. So I went into a frenzy and I sent links from NHS England, NHS Resolution, NHS Improvement. Also, I think one of the Solent Trusts have had very success with patient engagement partners, thanks to the Patient Safety Hub who presented it earlier in the year, the healthcare show. So I sent him all these links. But of course, they're the two key stakeholders. So how do you get past that barrier?
Do either of you want to take that first, and then I'm quite happy to jump in as well?
I think my initial reaction to hearing that is, there is clear evidence as to the benefit of involving patients in all aspects of our work, patient safety improvement work, our educational materials that we develop. We do that certainly within NHS Resolution and find it extremely beneficial. My question, I think, that we can't answer here is that individual fearful of something around involving patients? And if so, why does that fear exist and what can we do to address that? That's my initial reflection on what you've just discussed there, but I'll hand to.
I would like to ask those questions, but of course, how? Again, the nature of the moral system, I don't want to...
It's an incredibly difficult issue, I think, and this goes to a number of things, and I talked about this around the wider issues of Lucy Letby, of people speaking up, and it seems to me that you're right to do what you do. You have emailed them. I wouldn't encourage you to make a pain and a nuisance of yourself, but equally I would encourage you to gently try again and say, look, but surely we shouldn't. And I don't know if there's other ways. Other people in the room may have some thoughts about this. I'm not an expert. I'm not in the NHS, but I share your pain, if I can describe it as that, because actually I think there is, and there will be benefits from doing that, and it needn't be confrontational on a problem. So I thank you for sharing that. But yeah, I think it's a really good question.
Can I just ask, is this your patient engagement or patient experience team that are your stakeholders?
Sorry, no, it was my colleague in practice education. He used to
Okay.
have a neuro rehab course for nurses, so he's trying to redevelop it, level 7 accredited with the university.
Yeah.
So he came to me because I've done the course previously.
Okay. So my advice often, and I will say something else in a moment that might be a bit like squeaky bum time for people, but I'm always like that. My first advice would be speak to your patient engagement team in the trust. There will already be probably a patient group or a patient panel that will be involved, and that's really important to engage them, because as much as anything else, they know how to twist arms to do it right and do it well. So go find out who is your patient experience or patient engagement team and have a chat with them and tell them what is needed and let them do the difficult conversations. So then, as you rightly said, you don't then become the pain who's always asking for patient involvement. The squeaky bum thing I was going to say is sometimes we talk to other stakeholders who are also patients, and they go, oh no, don't involve anyone else because we're here. And I've got to be honest, and I will just say this because I've had that experience myself. Quite often, people in clinical roles don't wish to engage with patients because they've had a previous bad experience of engaging patients who have either become a pain in the neck and are only after one thing and on one solo issue and can't think more strategically because of the harm or because of the problem that's been caused for them. And what you have to do in those situations is go, Thank you very much for your input. It's really kind of you. However, I have a duty to involve the community that we serve. And that community that we serve is not just patients, but it is also the wider community and the people in the region. So you have a right not just to engage patients, but to engage patients, carers, family members, and people that have never been and will never be a patient because they are taxpayers paying for the service in which we are responsible for. So, yeah, my answer is work your way around it by using the right people, but also never allow one stakeholder to tell you that you can't involve another stakeholder. Other questions? Sir?
Thank you. So I work in a ICB, so I'm headless within ICB, so I work within that domain. My question was more around looking around integration and then looking at adult social care functions as well, and how we, whenever there's issues or things that go on with patients or individuals, actually it's a system response, isn't it? There's lots more people around there, so it's very health focused. But obviously then when you start looking in the realms of ombudsman, escalations with adult social care and all those kind of challenges and what comes through with sort of complex, how's the best way to sort of approach getting fair culture and looking at those standards across that health and care perspective, considering that there is different responses, authorities and things, especially when you're looking in places that have got Section 75 agreements where you've got dual responsibilities. So that would be my question around and how well received is things like this within the adult social care space for that consistent.
Thank you very much. The complication of the new world of integrated care boards against integrated care systems and then, of course, integrated care partnerships. Don't we love acronyms in this world? Can I come across to you guys first?
I'll go first. I mean, it seems to me that is the world that we're in, and we do have to find ways of joining it up and saying, oh, well, that's my bit and that's your bit and that's not my problem. It seems to me it's one patient and they're entitled to have that thing be joined up, and if something is not right, then unpicking that collectively rather than say, well, that's me and that's you and I'll pass the buck over there. So it seems to me part of the process of ICSs and ICBs is to try to bring these things together. It seems to me what must come from that is to bring together the processes of, well, when things go wrong, how do we join these together and have one holistic view of the patient rather than say, well, I'll look at this bit and I'll give that bit to you. Actually, it's one patient. They deserve one answer to that, it seems to me. Now, how you do that, I don't know, but that seems to me the very reason why we are joining these things together. So that must be one of the questions that comes out of all of that work must be, well, when it goes wrong, how do we make sure we have a joined up response?
Just come forward a little bit, I'm leaning too far back. Yeah, it's thinking about sort of the role of NHS resolution and learning from claims in particular. That's a challenge that we're currently grappling with. As a indemnifier, we purely indemnify the NHS. We don't indemnify the social care system, but they are interconnected. And if we look at the patient pathway, there are, failures, gaps along the whole way. So we are missing an opportunity just to look at the particular incident in isolation. So we have to think a little bit more broadly about how we can thematically analyse our data that we hold and look at it more broadly across an ICS. And that's something that Sam is currently looking at when looking at the general practice claims, looking at, well, how has the patient pathway been an influence here in this claim being brought? But it is a real challenge for us organisationally how we start to share our learning in a way that is applicable to the ICS rather than to individual trusts. But that culture piece is also really important. So we're currently running a series of ICS engagement events, working with trusts, sorry, that's a slip, isn't it? Working with ICSs to help them understand how whilst our Just and Learning Charter is
probably to some extent designed to work for organisations, actually they need to adopt the principles as well and think about how they can be applied across the entire patient pathway, not just within their individual role.
So for me, I would say you're now in the position that any patient with a multi-comorbidity has been in for most of their lives, in the sense that you're now having to deal with multiple organisations around a single pathway or a single person. And I would probably ask you to consider it much like a medical MDT, where we get everybody in the room to discuss around one patient pathway. The difference for me is you need to have the patient in the room. Whereas most MDTs still sadly fail to do that. They'll talk about a patient but not to the patient or with the patient. And I think as systems, we have to consider the difference between patient engagement in a single, as that individual patient, and patient involvement, patient engagement in strategy conversations. And so I would be saying that when we come down to things of patient safety and harm, you should be thinking about the individual and how that is impacting across the system for that. But as you look at system level, you should find and recruit very specifically lived experience voices to work with you in a style of an MDT that can look at patient pathways across the whole of the system. And that's what you're about. You're about, it's the whole difference between population health management at one end of a structure and personalised care at the other, and how do you take responsibility for both while operating both. And my response is exactly the same with the ropes. You can't do it until you get everybody in the same room together at the same time, strategically thinking, how do I make the best of this? Hopefully that helps. But you're in a brave new world, and I think it's a really interesting world to be in right now. Yes?
Hi.
Thank you. We'll come that way and then to the gent at the end.
Thank you. Samantha Thomas, Safety and Learning Lead for General Practice at NHSR. I just want to ask, where do you see EDI and cultural intelligence fitting into the patient safety agenda? As a nurse and a recent NHS super user, I just noticed that sometimes there's a hierarchy within the patient and doctor relationship where even if the patient is clinical, I still don't feel even in terms of getting listened to. So what hope do our patients have, and their cultural background may affect how they feel about challenging or contributing to that relationship with the healthcare professional?
Thank you very much. EDI approaches.
Yeah, I'll start on that because we're sort of doing an amount of thinking about that ourselves as an organisation as we think about our next 5-year plan, and how do we weave EDI into that, and what services are we providing? How do we know we're reaching all the right communities? We run a helpline. You know, we have some data about who comes to us, but I think we feel that we almost certainly need to do more sort of outreach work into communities, because I'm almost certain, judging on inequality in terms of healthcare data, that we are missing a chunk of people who should and could be using our service. So I think, I mean, there's a lot of evidence that supports the linkage between patient safety issues and health inequalities. So if that is the case, then we ought to make sure as a charity that we are doing all we can to reach all of those communities who could need our support and our help. So that's one of the things we're certainly thinking about at sort of a holistic level.
I think it's thinking about what we've discussed so far today. I think it's really important making sure that our patient voice groups are representative of our local communities and, you know, appropriately represented. I think that's probably a key area that needs some more focus on.
Thank you. For me, there's one real clear thing, which is recognition. So let's start with some recognition. We are an incredibly white middle-class panel. So you're asking a question that has a lot of depth to it, of people that don't have the same experiences of healthcare as yourselves. And that's really important to acknowledge. And people from different backgrounds, regardless of what that protected characteristic is, find it much more difficult than Mr. White middle-class man like myself to even get asked to come along to give their views and opinions. And you talk very specifically about your relationship with clinicians and the patient relationship with clinicians. It has to start, I believe, not just with the patient, but also with the recognition in the clinical world that for years we've taught people the wrong way. And what I will go back to my old days of consultant used to be God, and they are not. They sometimes make decisions that might make them feel and might make us feel that they are God-like, but they are not God. And the balance in relationship is really important. And the way I've described that in the past to people is, just do me a favour, remember when you were a child, put your hand up if you ever got on a seesaw with somebody. Right, so you all know what I'm about to, I hope you know what I'm about to say. Sometimes being on that seesaw was great fun, all right? Because you played together evenly, one went up, one went down, and think of it like the clinical and patient relationship. Sometimes as a patient, I'm in such a place that I actually need the clinician to take over and deal with things in a very urgent manner in order to help me. And therefore, I take my feet off the ground and let them take control. Equally, at other times, I want them to take their feet off the ground and let me be in control of my health condition and deal with the things that are important to me and manage that. But most of the time, what I actually want is a nice, even balance at which I can just chill out and chat and say, this is how I'm feeling about this, what advice could you give? And it is equal. And we don't teach people that. We teach people that they are always in control or wish to be in control. We actually need to be a bit more honest, both with our patients and with our clinicians, that it's an up and down relationship and it's up to you together to jointly balance that, no matter what the EDI concerns are. And I think we have to acknowledge, and I will say it, as a nation, we are still awfully racist, awfully bigoted, and awfully terrible at even acknowledging that. And the health service is a part of the nation and is no different than any other part of the nation. So you will come across people who are awfully bigoted, awfully racist within that community just as you will in your own. How we deal with that is more important, and most importantly is how we support people that have been wronged just as we support people who have been harmed through clinical care. We need to support people who have been harmed through other incidents such as racial abuse or abuse around any of the other protected characteristics that we are legally required to support. I hope that gives you an answer. Thank you. To the top, sir.
I was following on from the question about social care, so I feel like
We can bounce back and forth. It's not a worry.
I will leave your powerful statement. Mike Frobe, I'm part of Loughborough University, and we come at patient safety obviously from a research-based focused and just about to enter into an educational role as well. The part about transitions in care I think is a really important part of this, the brave new world of health and social care being sort of in some sort of continuum. And I don't think anybody thinks it shouldn't have been like that for 100 years, but it has been. And that the question for me, and I think this is maybe something that I hope people who are in that role can take away and try and do something with, that is that there is a real body of knowledge about transitions. It's almost all in acute health, and it's almost all from the focus of acute health practitioners sending people out into the wider world. What we don't see, and what we see almost zero funding for, is the other way around. And what we should be doing is looking at an individual as a care receiver and a social services department as a person collector almost into their service, and look at that research from the other way around. And I think that in the next 5 years, that would make massive difference if we swap that. And I think quite a lot of these things about health inequality and poor levels of service and people dropping through the gaps and all of that is because we're looking at it from our healthcare factory perspective, which is come in, do something, go out. And we can't. That will never give us the answer to how we successfully manage people going into the long-term care thing at the other end. We somehow need to transfer that round. And it felt like the right thing to say on the back of that comment over there. Thank you.
Absolutely, thank you. More of a statement than a question, but I'm really grateful. Thank you very much. Any other questions from you?
Yeah, I've probably just got a statement. I think I'm lead nurse for tissue viability at Buckinghamshire, so we're an integrated trust. And I think everything has become about budgets and saving money, and it is the focus of every meeting that we go to. Thank you. And it is affecting patient safety, and I think no clinicians come to work to do a bad job, but we've got a massive increase in pressure ulcers across our community and our acute services. But we have stacks of patients in corridors, on trolleys, because it's so busy that you can't go and check skin and stuff like that. We've got increasing falls, we've got increase in all those harms, and actually you can't keep cutting budgets and improve patient safety. It's very difficult to meet in the middle somewhere, I think, and I think that's an ongoing problem around this budget cutting of everything, of these teams, and, you know, I think that's just a comment. It's not particularly a question, it's just a comment from our trust, I think.
Yeah. I'm going to turn it into a question. Is there a way for organisations to do both their financial responsibility and keep patient safety focus at the same level, or do you believe that one should come before the other?
Thanks for that question.
Thanks for throwing that one in there.
I mean, I think, well, I was having a conversation. You made a comment earlier about PSURF, and then there was your apology for no resources to go with it, and I agree with that. I think equally we can make resources a reason for many things, and I think we just have to be guarded about that. I take the point absolutely you're making, and I don't doubt it for 1 minute, and I'm sure that experience is shared everywhere around the place in many trusts, and, you know, some will be in a better place than others, and, you know, that therein lies a sort of a political question about all of that and choices we make as a society about what we want to do. Does it mean that all aspects of patient safety therefore go out the window? I don't think they need to do. I think we have, on the upside, I think we have learnt many, many, many things over many, many years, such that actually we have come a long way in terms of improving patient safety, which are embedded practices day in, day out now, that weren't 30 or 40 years ago. So we have made good progress, and we shouldn't lose those. Equally, there will be situations which will be compromised for the very good reason you made. And I don't know the answer to that, but we have to, you know, that is what it is, I suppose, at the moment, until, you know, we as a society make a different set of choices, if indeed we choose to. So,
Thank you.
It's important to acknowledge, I think, that patient safety is always going to sit within those financial constraints, isn't it? But when I spoke at the beginning, I spoke about the clinic, the fact that our schemes are risk pooling. So your organisation is putting it'll be millions each year into the risk pooling scheme that we have at NHS Resolution. And how that amount is calculated is beyond my mathematical brain, but it does include claims risk profile. So if you're seeing an increase in pressure ulcer claims, a rise in claims related to falls, etc., that too is driving up your contribution that your trust is paying. So I think to some extent it's speaking the same language as those financial, you know, the directors of finance, and saying, look, you know, we've got this increase in falls, we've got this increase in pressure ulcers, this is how much we're paying contribution-wise on an annual basis, this is how much those falls are costing us on an annual basis from just purely a claims perspective, you know, without you know, even bringing into the patient harm aspect and the staff harm aspect, and using that as a lever for business cases to say, look, we've got to drive this down, and the way to drive that down is by whatever it might be that you recognise through your quality improvement activity. But I really do encourage looking at claims data and the contributions to help inform those conversations and build that business case that you desperately need.
My personal view on this is quite simple. That boards, unfortunately, do not have the skill still to look beyond what they call first finance. Now, what that means is they look at whatever they're being regulated on or at whatever their immediate cost is, rather than thinking secondarily, which is, if I don't do X, what is it going to cost me later on down the line? They think, if I do X, what's it saving me now? And that's a normal process of human beings. We all look at our monthly finances and spend to where we're at, rather than think, well, am I saving enough so that when something happens, do we have that? You look at the argument that's currently going on around wrapped concrete in schools. You know, that's a classic, not spending in advance to protect ourselves of future costs and payments. And you know, anybody that thought they could build a building for 30 years and say that that was okay, rather than what used to be building contracts, which was a 100-year building, then actually you're wrong. You know, you've done a major disservice. I think the same happens currently in our finance committees, and we need to be thinking much more about patient safety. Now, I saw 2 more hands. We'll try and get them both in, and that will then be our break, if that's okay. The gentleman here and the gentleman at the back straight after.
Hi, just some more information back to this recent question. Finance directors have a responsibility when they're developing cost improvement programs for the whole year, or even longer term, to evaluate each idea for improvement.
Yep.
And that needs to include things such as the likelihood of delivery and the timeline and things like, you know, the practical stuff. Is it going to really pay dividends? But the other dimension to this point is that they're responsible for making sure that any cost improvement initiative that's proposed is risk assessed, clinically risk assessed. And so if people are experiencing this kind of difficulty, they need to take these points back to the finance director or to the financial management person responsible for that clinical area and challenge them rigorously and say, you need to factor this in. It can't go forward without a clinical risk assessment.
Yeah.
And that's a long-standing best practice.
Yeah. Thank you very much. And you're right, the SIP programming is incredibly important in financial management of organisations. What I find as people go on through SIP programs, though, is that by the time you come towards the end of the year, they're trying to advance next year's programme in order to continue to make savings. And I've got to say, I will say it as an NHSE employee, NHSE are partly responsible for the pressure that is applied to ensure that financial probity is kept. It's a good thing, but it's also sometimes not the right thing. Last question from the gentleman at the top, please.
Again, I will echo what that gentleman has said. I think the frustration for me as a clinical director as a triumvirate, when we present this to the executives, is you present a case, you present the financials, you present the clinical risk, they listen to it. When it actually goes to board, it gets rejected. And that's the, you know, they approve, they say, you know, this is a sound business case for A, B, or Z, whatever it may be. The frustration is, at the end of the day, it gets rejected. And you think, I've done all this work, I've done the clinical risk assessment, I've done the financials, it stacks up, and we still get rejected. So that's where the frustration as a clinician comes in. The other thing I was going to say, I think, when I do review of harm groups or patient safety or, you know, review harms with patients, I think financial people should be in that meeting. They should really be there to understand the harm that has been caused to patients. You know, and if we had a monitor to do A, B, or Z, we could have prevented this harm. They would have had a length of stay which would have been 20 days shorter, and that's the cost saving we could have got. But it just doesn't stack up to the financials, and That is what frustrates me as a clinician more than anything else.
I think I'm going to slightly protect them. I think finance directors get a rough ride sometimes. I don't, as was said earlier, I've never met a member of clinical staff who's ever come to work to do a bad day's job or not to cause protection. I've never yet met a finance director that when I've sat down and had a coffee with them hasn't gone, I'm really in this to try and get the best for our patients. And I think what we actually need to do is realise that we're a team working together and we need to work together in order to get the best for everybody. All right, okay. Now, you said you were a tissue viability nurse, yes? Well, just for you, we are going to make sure that we all stand up, have a walk around, and make sure that we do not have any pressure ulcers. We have a 10-minute break, purely as a comfort break. Please come back in time for us to start at 10:50. Thank you very much.